Well, we had 150 registrants. I guess the weather is interfering. So I'd like to thank you all for coming despite the weather. I'm Rick Peters. I'm president of the Boston Medical Library. And this lecture is the 44th annual Garland lecture, which, oh dear. Dale? Just do this. Okay. Which is named in memory of Joseph Garland, who was a pediatrician on the North Shore until he started assisting Walter Bowers as an editor of the New England Journal, and in 1948 became the editor of the New England Journal. He's the longest serving editor, at least in the modern era, of 20 years. And he was also president of the Boston Medical Library for what was then the normal 3-year term. So this is in his honor. So I'd like to thank the Garland Lecture Committee, Scott Podolsky, Janine Saldana, Glenn Markinson, William Mackey, Nadeem Karambux, J.J. Asankar, Hugh Kaplan, Carl Benedict, and especially Dale McGee, the chair of the committee, who I'd like to now have introduce the lecturer. Thank you.
Okay, thanks, Rick. I would also like to, in addition to thanking the other members of my committee, thank Tara Peeler, who was responsible for organizing this conference and really did an extremely good job in getting everything organized for this, and I'd like to just acknowledge her right now as well. Now, with regard to our topic today, you can't pick up a paper these days without hearing something about referring to universal coverage, Medicare for all, something like that. And that's good news for those of us who are interested in health policy and would like to see things improve and like to see an advancement in this field. But unfortunately, most of what we read is a little more than ideology or slogans. We don't really get much in the way of details. And those of us who are interested in trying to make informed decisions don't have the meat there to really go forward with it. So that's the point of this conference, to give us some facts, to give us some reality to deal with. And we are lucky to have Benjamin Sommers here to speak on this topic. He's a graduate of Harvard Medical School. He also trained in internal medicine at Brigham and Women's and holds a PhD from Harvard in health policy. He is a professor of health policy and economics at the T.H. Chan School of Public Health and an associate professor of internal medicine at Harvard Medical School. But particularly important for today, he worked from 2011 to 2012 at the Department of Health and Human Services in Washington during the implementation of the Affordable Care Act and has extensive experience dealing with the details of implementing universal health coverage. His research has been published in journals such as the New England Journal of Medicine, Journal of the American Medical Association, Health Affairs, and many others. He's been covered by the New York Times, the Wall Street Journal, the Washington Post, and interviewed on NPR. And most recently, his work appeared just last month in JAMA in an article dealing with the effects of Medicaid waivers on health outcomes. So we're very lucky to have Dr. Ben Sommers here today to talk to us on this topic. Welcome, Dr. Sommers.
Thanks so much to the Medical Library for having me, and I just want to say, like the Red Sox, they track attendance based on paid attendance. I see 150 people here. Whether or not you're actually all in the seats, I'm going to count it that way. So I'm looking forward to talking today about Medicare for All. You'll see question marks here, universal coverage, options, evidence, and what comes next. And the goal for today is to start out by talking terminology. I think one of the messages I hope you take home from this is that it's easy to waive these terms and mean very different things by them, and so actually understanding what's being proposed and what's at stake is important. Talking about the policy goals of Medicare for All and some of the other terms that we'll discuss. What does health insurance actually do for people, since the main goal, the primary goal of Medicare for All is to get more people covered? And then what are the current gaps in the system that would be addressed by this sort of policy? And then we'll talk trade-offs. I'm an economist. You can't talk policy without trade-offs. So what are the potential trade-offs, and which of them are potentially overblown? Which ones are really more concerning that we should weigh carefully in the different options for policies? Costs, access, quality, and choice. We'll talk some politics. That's not the focus of what we're going to discuss, but it's some important context. And then leave at least 15 minutes at the end for discussion and Q&A. And I look forward to hearing what you have to say on that. Okay, disclosures at the outset. My work has been funded by the federal government and by nonprofit foundations listed here. No commercial interest to report. I did work as a senior advisor in the U.S. Department of Health and Human Services, a year in Washington, and then 4 years I was doing some part-time consulting here for HHS. But this talk in no way represents any of those organizations. These are my views. All right, so let's start with the healthcare dictionary. It's time for Medicare for All. This term has really kind of taken over and crystallized the public debate about fundamental changes to healthcare. But if you unpack it, depending on who you're talking to and what policy you're looking at, it's neither Medicare nor for all. So we have to be specific because there are versions of this that are clearly Medicare and they're clearly for everybody, and there are versions that are not. So what does it mean when we talk Medicare for all? Well, just stepping back from the idea of what is Medicare, well, Medicare is, as I think everybody in here probably knows, is the federal program for health insurance for the elderly, for people with long-term disabilities, and those with end-stage renal disease. But there are different flavors of it. There's traditional Medicare, where the government collects the bills and pays them out. This is so-called fee-for-service Medicare. But then there are also about 30% of Medicare beneficiaries who are enrolled in private plans, where the money gets sent through a private insurer who provides, decides the benefits, the network, and then sends that money along to providers after people get seen. And then there are also discussions, actually some of the most prominent proposals for Medicare for All are proposing something that is much more generous than traditional Medicare, and we'll talk a bit more about what that is, filling in gaps in terms of how much people pay out of pocket, thinking of some of the benefits that are not currently covered in Medicare. And is it really for all? Well, if you'd asked me 2 years ago, I would have said, well, yeah, Medicare for All is a universal single-payer health insurance program, and I'll define some of those in the next slide. But having watched the last year of political debate, it's become clear that this is a popular framing that often gets adapted to describe policies that aren't really universal. So for instance, we hear people say things like Medicare for all who want it, in parentheses, or Medicare for all, but that only really applies to people who are near retirement and might buy into Medicare. We also hear this term sometimes used to describe something that's probably more accurately referred to as a public option, but really only in the health insurance marketplaces. The Affordable Care Act created these places to come buy private coverage for people who don't get insurance through work. And some have said, well, we want to offer a public insurance option, like either a Medicare BuyIn or a Medicaid BuyIn, and sometimes this gets kind of lumped under the same heading. So we want to be careful with our terminology, and so rather than kind of use the Medicare for All as our operating principle, let's actually talk about what's in the different proposals. And to do that, some related terms that are important for us to understand is the first is single payer. Straw poll, how many of you heard the term single payer before? All right, almost everybody. Single payer traditionally means there's a single government insurance plan for everybody, and the payer here means who's paying for health care. The federal government is paying for health care. In some countries, we know it's actually not the federal government. It might be provinces, for instance, in Canada. But there's a government entity that's providing insurance to everybody, and they're paying for the cost of that care. There's also socialized medicine, and I don't mean that term in a demonized way. There's actually a definition of it, though it's mostly used politically these days. The difference between single payer and socialized medicine is basically, well, who do the doctors, the nurses, and the hospitals work for? In a single payer model, you can have it that the government's collecting all the insurance money through taxes and paying for everybody's care, but the doctors work for themselves or for a private hospital network or a group practice, and there's a private sector that's still very much at the center of healthcare delivery. In a socialized medical model, which we have one in the actually two in the U.S. Anybody know what our two socialized medicine systems are in the U.S.? The VA, right? The doctors, the nurses work for the federal government, so the Veterans Administration, and no, those are mostly state. So Indian Health Service is the other one. So Indian Health Service is doctors, hospitals, nurses work for the federal government through money that's funded by allocated by Congress for the care of Native Americans. In the international spectrum, this is what we see in England. So the UK has the National Health Service, where most providers are working directly for the government. The Canadian model that is often discussed in terms of single payer is not a socialized medical model because the providers still remain in the private sector. Finally, universal coverage really is a statement about just levels of insurance. And universal coverage means everyone has insurance. It doesn't tell you how they got it. It doesn't necessarily rule out private coverage, public coverage, or some combination. So some policymakers lump all these together and will just say Medicare for all, but we want to actually be specific, and one way to think of this is beware of slogans in lieu of policy details. Unfortunately, policy details rarely get you elected, slogans do, but we're going to try to unpack things today. Okay, so what's the purpose of any of these forms of universal coverage, whether it's a Medicare for all, whether it's a single payer that isn't using Medicare, or whether it's a combination of public or private insurance? Goal number one is to cover the uninsured. And this may sound obvious, but let's talk about what that means and why it matters. So who in the US still lacks health insurance? And what are the implications for them in their lives? Here's where there's a lot of evidence on this. So first off, who's still uninsured? Well, the Affordable Care Act, passed in 2010, fully implemented in 2014, led to a historic drop in the uninsured rate. The number of Americans, the number of people living in the US who didn't have health insurance dropped by about 20 million between 2013 and 2016. That's the biggest drop in the uninsured population since the creation of Medicare and Medicaid in 1965. So though a lot of, both from the right and the left, there are a lot of critiques of the ACA's shortcomings, it had an enormous impact in terms of getting more people insured. But there's still 30 million left uninsured, and if you squint, you might notice that the last point here in 2018 starts to tick up. So for the first time since the Affordable Care Act was passed, the Census Bureau announced earlier this year that the number of people in the US without health insurance has gone up by about 1 million. And there are a variety of reasons. We can get into that in Q&A. A lot of that is likely based on the way that states and the federal government have been implementing or peeling back aspects of the Affordable Care Act. The economy remains quite strong. There's not much reason to think this is about people losing employer coverage. But so there's this little uptick that shows that the coverage gains are not necessarily permanent, and policy decisions will have to be made going forward. Whether or not it's single payer, there are still going to be other decisions that need to be made related to the uninsured. Okay, so who are the 30 million who are left uninsured? Well, this slide, first off, is a little bit misleading in the sense that it makes it seem like there's a static population of people without coverage. We know from decades of work that insurance in the US is not a permanent state of being, and many of you can probably attest to this. How many here in the last 5 years have changed the form of health insurance you have? So about a third. That's slightly lower than the national averages, but in the ballpark. So it's very common that people move in and out of health insurance. They lose a job, they go a couple of months without any coverage, or they are in public plans, but maybe their income goes up and they can't qualify for Medicaid anymore, and then they ultimately end up in a new private plan. People go on the marketplaces and buy plans there, but sometimes those plans go out of business, and people may take a few months to find a new plan. So this is not a static group of people. This is at any point in time, there are about 30 million people in the US without health insurance, but it's in flux of who's in that population. What do we know about them in terms of the snapshot, though? Well, half of them are actually eligible for subsidized coverage under the Affordable Care Act. And this splits roughly evenly into folks who are eligible for Medicaid but not signed up, and people who could get a tax credit to buy private coverage through the insurance marketplaces but also haven't signed up, or in some cases signed up but then dropped out. Why might somebody drop out of coverage that's subsidized and in the case of Medicaid generally free? Well, in both of these programs, it's not a permanent entry. Once you sign up, you have eligibility for a defined period. It's typically 12 months, some cases less. If your income goes up, if you move, if you've had a change, if you get married, you get divorced, your kid moves out of the house, all of those can be potential reasons that you might no longer be eligible and you might fall out of the program. And even if you are eligible, you may not know that. So you have to apply for these programs. This is not like Medicare, where when you retire, you typically automatically move into Medicare at the same time that your Social Security check starts getting deductions for the premiums. For Medicaid, you have to go to the trouble of applying, and many people either don't know or have trouble navigating that system. So there are a couple ways you can react to that fact, knowing that 50% of the uninsured is already eligible. So one policy approach would be to say, we don't need to overhaul the system. We just need to do a better job getting this group covered. So for instance, if you look at Joe Biden's proposal in the Democratic primary, that's essentially the approach he takes, which is, let's look at each of these buckets and target a policy that gets that group more likely to enroll. Could we make subsidies a little more generous so that people buying these private plans don't have to pay as much out of pocket? Could we do other things to stabilize the marketplaces to make sure insurers don't drop out? And those are some of the steps that his plan offers, including a public option in the marketplace, which could potentially offer a lower cost alternative to people and might get more people enrolled. You can also do basic things like better advertising, right? You can give people longer to sign up. The Trump administration cut the period that people could enroll for these plans in half. They also slashed the funding for advertising to let people know about open enrollment period. We also know states are implementing additional barriers to Medicaid coverage, for instance, requiring that people work or demonstrate that they're working to keep their coverage, which the only state so far that's put this into effect had 18,000 low-income adults lose coverage in the first 6 months. So some of these things can be dealt with without an overhaul, with more targeted approaches. You can do things down here then at the 9% in dark blue. This is the group of people who are in states that have yet to expand Medicaid. It's currently about 17, depending on how you count some of the states that have passed ballot initiatives but haven't put them into effect. So with about a third of the states in the U.S. not expanding Medicaid under the Affordable Care Act, this is a population of about 2 to 3 million people, while small in absolute numbers compared to the rest of the pie, are probably the highest need. These are people who have incomes below the federal poverty level, high burden of chronic disease, and are disproportionately people of color, subject to longstanding disparities in health care, and disproportionately living in states in the South that have very restrictive social safety net programs. This is a population there that, if their states were to expand, would probably have the biggest health impact. So even though it's a small absolute number, if you're kind of prioritizing where do we see the potential biggest benefit of expanding coverage, that this is one place that a lot of people have looked. There's another 9% who are not eligible for marketplace coverage because they have an offer through their job. ESI here stands for employer-sponsored insurance. If you have what's deemed by the ACA as an affordable offer of coverage, if you don't take it, you can't get a tax credit. But the reality is most people want health insurance, so someone who isn't accepting the offer from work, it's because it really wasn't affordable for them. And we'll talk more about what the numbers on that look like. What are the types of plans people are seeing? Finally, higher income people, those with 400% of the federal poverty level or above, they're not eligible under the ACA for any subsidies towards health insurance, and some of them, even if they want coverage, may not find something that they feel is affordable. Again, you could take a targeted approach and say, well, one way to deal with that is to make tax credits go higher up. And finally, then there are an estimated 4 to 5 million undocumented immigrants in the U.S. who are not eligible for any subsidized coverage under federal law. So you can take this patchwork approach, or you can say, why take a patchwork approach when we can cover everybody with one policy? And even those patchwork approaches I mentioned are unlikely to get everybody, right? You can make the subsidies more generous, some people still won't want to pay anything. You can make Medicaid easier to navigate, some people still won't get enrolled or will drop out. So if your goal is universal coverage, single payer is simply the easiest way to do it in terms of getting everybody enrolled, making it automatic, making it lifelong. And that is, at its core, the simplest and most important argument in favor of doing it. Well, why do we care if people have insurance? Fortunately, the last decade has given us hundreds of studies on the impact of gaining health insurance. Because that big drop in the uninsured rate under the ACA has given us a way to study this, we now know much more about what health insurance does for our patients than we did a decade ago. So what do we know? And this is just a sprinkling of some of the evidence on the impacts of gaining health insurance. Surgery patients get more timely care and they get better outcomes. So for instance, they're less likely to have a limb amputated because they have poor blood flow. They're less likely to have their appendix burst before they come in for care. Adults with depression, one of the leading causes of disability and poor health in the country, report better access to care. They're more likely to have visits and more likely to take medications, and those are the mainstays of treatment for depression. People overall say they generally feel better. Not every study shows this. There's some mixed results on this, but the majority of studies do show it. And it's important to know that because A, we should care how people feel, right? If you're a doctor and you say, well, I only want to know your blood pressure, don't tell me if you feel better, you're not a very good doctor. But also it turns out if you follow people over time, if they tell you that they're in poor health, they die at 2 to 10 times a higher rate than people who say their health is excellent. So if someone tells you they're in bad health, you should believe them. And as policymakers, we should really be concerned with this measure. For chronic conditions like diabetes, heart disease, and asthma, we know people are more likely to have a regular provider. Now, some of the studies have not found improvements in the chronic disease measures like blood pressure control and diabetes control. So it is not the case that insurance always leads to optimal outcomes. But there are enough studies that show that we do improve some of these measures to conclude that there's a health impact. And finally, we know that there's improved survival, and this is from a series of studies, some pre-ACA, some that our team worked on here in Massachusetts, several states that expanded Medicaid pre-ACA, and then there's some promising work that's coming out now that's post-ACA showing that the Medicaid expansion nationally has been linked to reductions in death rates. So you put all of this together, health insurance matters. It matters for people's health, it matters for their ability to access care, to pay for that care afterwards. Now we can get into some of the other impacts, how this affects hospitals, physicians and other clinicians, the overall economy, and that those are important issues. But let's segue from this now into thinking, what else do we want to do besides just getting everybody covered, which again is goal number 1 and 2 and 3 and 4. If we move down the list beyond that, what else do we try to accomplish by looking at something like a single payer or another universal coverage model? The second issue is that even though 90% of the population in the US has health insurance, that doesn't mean that there are no problems with affordability. Right? We actually know that there are significant areas where the system leaves people exposed to high healthcare costs, and that this problem is getting worse according to multiple measures. So one way to define this is to use a term called underinsurance, right? So we talk about the uninsured. We can also talk about underinsurance, where people have coverage, but it doesn't provide them with enough financial protection to make their finances secure and to make sure that they have access to the care they need when they need it. Big contributors to this include high out-of-pocket premium shares, so people who get their coverage through work but have to pay a lot for it, and then high out-of-pocket cost sharing, co-pays and deductibles. Deductibles have gotten a lot of attention in the discussion about the Affordable Care Act, and with good reason. The average plan that someone purchases in the silver tier, the ACA ranks plans by metal level, so there's a bronze, silver, gold, platinum. The most commonly chosen plan is a silver plan, and the average deductible, this was about 2 years ago, was $3,000. So pretty substantial, well beyond what most people have in terms of assets ready to pay for a medical emergency. But it's not just in the marketplace. So a study out earlier this year showed that the average deductible in employer plans is now $1,600. So this is the private form of coverage that the majority of Americans have, over 150 million. And this tells you that many of them are struggling to afford the care they need. When you ask just broadly a very basic measure of can you get the care you need when you need it, about 15% of the US population, and it depends on the survey you look at, but 15% in 2017 said, I put off care that I needed because I couldn't afford it. So I'm telling you, 10% of the population is uninsured. Then there are also a lot of people who have coverage who are still saying, I can't get what I need. Okay, so we can cover the uninsured. We can improve affordability for all. Goal 3, reduce costs. Right? We can't talk about health reform without getting into how we're going to pay for it. So let's be specific, though, about how can a Medicare for All or a universal coverage plan reduce costs. The alternative is not straightforward, which is that basically patients and providers have to decide how to spend less money. This patient wants a cheaper diagnosis. So how does a single payer plan actually reduce total healthcare costs? There are 2 potential avenues that are the main ones. Now there's some other smaller things we can talk about as well, but you don't have to do single payer to get these. Administrative simplification. So what am I talking about there? How many of you work in a healthcare setting or have in the past? Okay, so you know that in the healthcare office, and whether it's a doctor's office or a hospital or whatever, that there are clinicians and then there are billers, right? There are people who are behind the scenes doing everything they can to collect bills. If you don't work in a healthcare setting, how many of you ever gotten a letter from a healthcare billing entity, right? Everybody, right? This is not kind of an incidental feature of the US healthcare system. It's really a defining feature of how much energy goes into administration. And this is for several reasons, but the most obvious one that relates to our conversation here is that there are numerous payers, right? If you run a practice, you might be in the network for 6 or 7 managed care plans. You might be taking traditional Medicare, traditional Medicaid. You might be taking Medicaid managed care plans. You might be participating in a Medicare Advantage private plan. And for each of those, there's separate credentialing, there's separate paperwork and billing requirements, and even when they're trying to be aligned, they're not really aligned. And so this is why we have these huge billing offices everywhere, right? So if you go to a single payer, and here the single payer term is very clear, right? A single payer, not flavors of it, but one type of payer for everybody, you don't need that, right? So that's the simple way to save on administration that can have substantial savings, and I'll quantify that for you in a slide or 2. Then the other big feature, and it depends on what audience you're in, whether you hear this focused on, is a single payer model offers the possibility of saving money by paying less, right? The federal government is in the position, if it chooses to have huge bargaining power. If everyone in the country had a single insurance plan through the federal government, most providers won't be able to turn away and say, I'm not going to see those patients, right? If, for instance, right now, there are essentially no hospitals that are general hospitals that are not taking Medicare, because it's hard to stay in business if you don't accept Medicare patients. Now, on the outpatient side, that's not true. And we see boutique medicine, we see people who take a limited number of Medicare or Medicaid. But if this is the only game in town now, and you want to provide healthcare in the US, what are you going to do? You can't easily walk away. Now, you could walk away from the profession. We can get into that. You can close your doors. But if you're going to treat patients, you're going to have to take the price that's given. So the federal government now has leverage. The federal government does not use this leverage in most aspects of healthcare currently. The exception is the VA. The VA does do negotiating in this way. But Medicare does not negotiate drug prices, does not really do as much of an aggressive negotiation on prices to providers as potentially they could. So this is a savings to the system. It's a loss if you are somebody who gets paid this way, right? So savings to the system, but decreased salary to doctors, to nurses, to hospitals, and so you can start to see where the political controversy is going to come in. So how do we quantify this? Well, one way to do this is just to look next door, right? So the Canadian system does use a single-payer version, a single-payer policy. Each province runs its own centralized government-paid health insurance. And one study by folks here at Harvard found that if you compare why are the prices so much higher in U.S. healthcare than Canada, 39% of that cost difference is attributable to this administrative burden. This paperwork, red tape that's really not helping anybody get healthier. It's just making sure that the right people get paid by the right insurance. Then 31% of the price difference is that hospitals and clinicians in the U.S. get paid more. Right? Salaries are higher. That's even true in general for primary care. I'm a primary care provider. It's like in our blood to be told that we're underpaid. Well, when you look globally, the U.S. primary care force doesn't look quite so underpaid anymore. And then if some smaller piece of it is that we're doing more care. The 14% here is that you're more likely to get certain kinds of advanced imaging like MRI and CAT scan, but that's not driving it. The big issue is we have a more administratively cumbersome system, and we pay our doctors and hospitals more, and our drug companies and our device makers. So these are some places you can recoup a lot of savings, but it's not going to come without significant trade-offs and political battles. Okay, but I talked a lot in that goal number 2 about how we pay for care in terms of affordability. And there we have to look at a countervailing force. If we want to make things more generous and cover more benefits that are not in traditional Medicare, well, that's going to drive total costs up. So we're going to be trading off. We're going to save on administration, we might pay lower rates, but we're going to cover more stuff and people will use more stuff. And in fact, we can quantify that because there have been a lot of studies looking at this. How do copays, cost-sharing deductibles affect how much health care we get? Now, you might think, well, but people only want the health care they need. The problem is there's a lot of gray area, right? If you practice medicine, you know there's a lot of gray area. And if you're a patient, you probably had the time where you thought to yourself, do I really need to go in tomorrow, or should I wait and see if this gets better on its own in a few days? And it turns out if the care is free, you're much more likely to go in tomorrow. And if you have to pay deductible, you're much more likely to wait a few days. So what do we know about these numbers? Well, this first study that really looked at this is now getting quite old. This is a study that started in the 1970s. But the reason we still talk about it is because it's rare that you get to do a big randomized trial in health policy. This is the RAND health insurance experiment, where they assigned several thousand people into different categories of random types of insurance coverage. Some people were getting free care. That meant they had no copays at all. They could get whatever services they wanted, fully paid for. Some people had to pay 25% out of pocket. That's the second line. Some were paying 50% out of pocket, and some essentially had a deductible where the insurance really didn't pay for much up until they'd spent several $1,000s. After several $1,000s, the insurance kicked in for everybody. What did they find? Well, if you just look across the top bar, now these dollar values look really small, right? Healthcare was much cheaper, even adjusting for inflation back then. But you see that the people who got free care, no copays at all, spent about $2,800 in inflation-adjusted terms, whereas the people who had this big deductible for the first couple thousand spent $800 less. And this amounts to a 30% cost difference. Now, you might say, okay, but they probably got really sick. Well, it turns out that for the most part, they cut back on visits. When they went for visits, they got similar levels of care. And for most health outcomes for most people in this study, their outcomes were similar. So they were spending less but not sicker for it, but with a couple of big exceptions and caveats. For lower income individuals who have chronic conditions, outcomes were worse. So for instance, blood pressure control was worse for low income patients. They had more trouble affording vision care and dental care. So there are some outcomes in vulnerable populations that this cost sharing is more problematic. And the other big caveat is this was 1970. I like to think the medical care we provide in 2019 has more value and more health benefit than what was being done 40 to 50 years ago. So is there any more recent evidence? Well, yeah. And it's consistent with the basic story there from the RAND study. So a prominent economic analysis 2 years ago that looked at a large employer that shifted all of their workers into a high deductible plan. They found that the immediate impact was a 12% reduction in spending, so pretty substantial savings. And again, mostly because people had fewer visits. It turns out giving people a big deductible doesn't make them price shop. They don't kind of carefully consider who to go see. They just go less. And is that a good or a bad thing? Well, you have to unpack what they were doing then. So for instance, some of the stuff that they were putting off getting was probably good. We saw a 45% reduction in people getting antibiotics for the common cold. We know that the antibiotics don't do anything for viral infections. This is not only not beneficial, it's actively harmful, right? We create antibiotic resistance, people can get allergies, so that's good. So you say, great, the deductible scared people off of getting inappropriate antibiotics. We like that. But at the same time, and this is just a handful of the outcomes, but I'm highlighting two here because they're so clear as to the impact. So really good to cut back on those antibiotics, but we see people waiting 3 months before going to get care for a stroke or chest pain in patients who are at high risk with diabetes. So a high deductible making people wait 3 months to get care for those conditions is really problematic. So the upshot here is when you make people pay more, they come in less, they wait longer, and we save a lot of money, but we probably are dissuading some valuable care too, especially if they're sick and especially if they have low income. So you put that together, and that's the rationale of why we would think about making sure that people have more generous coverage up front with Medicare than the current system exists. The downside is it's going to cost us more, and it's going to eat into some of those savings from the administrative or the cost negotiation, price negotiation. So let's step back here. And again, this is where the Medicare for All term is a bit misleading. If we actually look at what Medicare pays for now, it requires people to chip in a lot of their own money. So Medicare Part A, which is the hospital portion of the program, people have a $1,300 deductible for their first hospitalization. Basically as high as what we were worrying about on the employer side. There's a copay of $341 per day in the hospital after you've been there 2 months. As many of you know, we all know that with catastrophic illnesses, people can easily exceed that in a year. And then they're up to $682 afterwards, and you only have 60 days of coverage beyond that threshold in your lifetime. There's also no catastrophic cost cap in Medicare. So there is no guaranteed limit that you hit a threshold and now Medicare will cover the rest of your costs. I'm not trying to alarm any of you, but if you didn't know that about your Medicare coverage and you haven't, you might want to look into some of the details. Now, Medicare Advantage does typically have a cap, and so that's not quite the same issue for the 30% there. And overall, if we just kind of take people's coverage across the board, we see that Medicare is paying about 80% of costs, but that means people are on the hook for 20% out of pocket, which is not trivial. And because of that, most people actually supplement their Medicare. So 30% here this is everyone who has traditional Medicare that they're not getting through a private plan. 30% of people use a retiree benefit plan to cover some of those extra costs. 29% buy something called Medigap, where you go directly to the insurer. You probably have seen the commercials. ARP sells one that's heavily marketed, and you get to fill in a lot of the copays with this private insurance option. If your income is low enough, you can qualify for Medicaid to pay for these copays and deductibles. But about 20% of people don't have any supplemental coverage. So if we talk about Medicare for All, this is where you want to say, well, what Medicare? Is it traditional Medicare on its own? That's probably not going to solve a lot of people's affordability problems if they already have insurance. It will certainly help people who are uninsured. But that's why a lot of the proposals feature much more generous cost sharing. So it's being called Medicare, but that's essentially using the brand name because it's got name recognition. But what they're proposing is either Medicare Plus or something really, just much more generous than what we typically see as Medicare. All right, so we're doing all right on time. So we're getting into trade-offs now. So we talked about the ways that you can reduce costs through a single payer plan, but that then raises the natural question about access to services, right? If we have a single government plan, will we still have the same choice of providers? Will people still be able to get in to see the doctor? Will the hospitals that are currently, financially on edge, are they going to have to close their doors? Well, there's no single answer to this. So, this is going to be kind of the unsatisfying economist on the one hand. On the other hand, it really depends on the choices you make. If you implement payment rates that are more generous than currently in Medicare, there's no reason to see any closures of hospitals. There's no reason to see any providers that are balking from seeing patients. But on the other hand, then the price tag becomes more prohibitive. If you do negotiate down some of these prices, you will potentially have some clinicians who say, I'm going to see fewer patients, or I'm going to go into boutique medicine and only take cash payment. And you might have some hospitals close. Now, one thing I'll say is that in isolation, you can't really talk about Medicare payment rates and say, well, look, Medicare pays 40% less than this insurer for that plan, and our hospital would have to close its doors. That implies that hospitals and clinicians more generally have no kind of free will to adapt, right? If a hospital suddenly finds out that they're going to get reimbursed 30% less for services, rather than all of them closing their doors, many of them will have to reconfigure their business model, right? We might see fewer fancy atria. We might see fewer hospitals that are buying up other practices to try to increase their referral network. But that doesn't mean they all close. So this is what in economics we refer to as a general equilibrium. Basically, the idea here is when you change something pretty dramatically, you shouldn't assume everything else stays the same. There's no reason to assume that hospitals will maintain the exact same business model if the way they're getting paid dramatically changes. Now, will that be a satisfying outcome? Well, it depends again on how much you've cut the payment rates and to which hospitals and in what context. But it's not immediately obvious that you can just extrapolate and say, well, here's how much we get underpaid now, we'll all close if you do this. It also matters what you put in the laws to what clinicians are allowed to do. Is a clinician allowed to say, no, I won't take universal Medicare, but I will charge you cash payment if you want to see me tomorrow? You could outlaw that, or you can allow that. That has an important set of issues for access and choice, as well as equity. And will there be any kind of supplemental private insurance market? Some countries that have universal coverage allow you to buy extra insurance that gets you better services or more timely access. That's a policy choice, again, that has to be made. And then a lot of this also depends on what the universal coverage looks like. If it's a single payer, but it allows Medicare Advantage to continue, where there are a lot of people getting these private plans, well, then you'd imagine there's room for people who are currently taking Medicare Advantage to continue doing so. So there's a lot of gray area here, and it's not clear. You can't say kind of in a universal way access would be better or worse for people who already have coverage. It depends on these choices. What about quality? So let's say you can get in to see a provider. Will the quality be better? This is where the outcomes are pretty unclear. In part, this is because we don't still have a great handle on quality in the healthcare system as is, right? It's very challenging to measure it. We've spent the past decade under the Affordable Care Act piloting a whole bunch of programs related to pay for performance, bundled payments, accountable care organizations, all of these attempts to get hospitals and clinicians to provide high quality care as opposed to just high volume care. But the results are pretty mixed. Some of these programs have not worked and not saved money. Some have saved money, but at the potential unintended effect of worse outcomes. And some have had modest savings and stable quality. So given those findings, we really don't know what something like a dramatic overhaul with Medicare would do. We do know that it's really hard to assess quality when you have a diverse population that's got a lot of different socioeconomic and clinical challenges. So for instance, we know for decades that if you look at people in Medicaid, that they have worse health outcomes than people with coverage through work. Some people have taken this and said, well, that means that Medicaid's no good. Well, Medicaid was designed to cover people with low incomes, many of whom who have disabilities as the way that they qualify. So of course they have worse health outcomes than high-income people who have jobs that provide health insurance. So the same challenge exists for policymakers who want to improve quality, and that would apply just the same if we were to go to a single payer model. We'd have a lot of difficult choices to make as to how to structure the payment incentives correctly. And it might make things better, it might not. My general hunch, and this is kind of just my gestalt reading of the literature, is we're probably not talking a dramatic change in quality by shifting to this. The access question is a little more up in the air because if you do have a lot of providers that are not willing to see this type of plan. But it's really important to remember this fact, which is the quality of care and health outcomes for people who have no health insurance is really bad, right? And so this comes back to why does health insurance matter? Well, the 10% who get covered through a universal coverage system are going to have major improvements in their ability to get the care they need when they need it. Okay. Finally, talk a little bit about choice. And what I mean here is how we allow or don't allow consumers or patients to have different preferences for what types of healthcare they want. So a true single payer plan, meaning a single insurance plan for everyone, reduces patient choices considerably. I don't think this should be a controversial statement. Now, you may say, I don't care. I'm much more concerned with saving money and getting everybody insured, and that's a very defensible position. But right now, there are a lot of choices that many people have in terms of healthcare, right? If you're in Medicare or Medicaid, most places you have a choice between several managed care plans and or traditional fee-for-service Medicare. If you have an employer plan, many employers, though not all, do offer more than one plan or more than one carrier. If you go on the health insurance marketplaces, you have a lot of plans. Does that matter to people? Well, yeah, all else equal. Some people are going to want a plan that has this network or that network. Some people are going to want higher copays because they think they're in good health and not worried about it. Other people want good first dollar coverage. And those are choices that the current system gives people some flexibility to pursue. Now, how about seeing a provider? Well, that's a little less clear. A lot of the plans people have now are fairly restrictive in terms of the physician network and other in hospital networks. So it could be that shifting to a Medicare-for-All or SinglePayer actually gives you more choices for clinicians, but it will certainly give you fewer choices for the type of insurance. Again, that doesn't mean that the policy shouldn't be pursued. It just means that's one of the trade-offs. And that may be a low priority when you think costs, access, quality, health equity. Consumer choice may be low on your list, and that's a defensible position, but I don't think the answer is to say, well, there actually are no compromises on choice. Now, in part, we see this manifesting in the Democratic debate right now in the primaries, where one of the big arguments we're seeing against a single-payer sort of plan that, say the Bernie Sanders plan, is moderates who say, well, we'd like to maintain choices for people. Why not give people the option for Medicare if they want it? And if they don't want it, they can stay with what they have. Or if they sign up, we're not just going to have a single Medicare plan. Let's keep using these multiple Medicare Advantage plans so that we can have everyone covered. Medicare's the framework, but we let people pick for insurance. Well, the downside of that is if we keep 10 different Medicare Advantage plans in place so people have some choices, remember all those cost savings we were hoping to use to help pay for this? Well, if there's still 10 different insurance systems in place, we might save a little bit of money, but we have not gotten to that super streamlined Canadian version that 39% cost savings comes from. Finally, and then we'll get to some Q&A and discussion. After all this, with this evidence and these trade-offs in mind, is Medicare for All possible? The answer here, hopefully you were ready for this, is, well, what Medicare for All do you mean? And also, what's your time frame? So here's a couple quick factoids on where the public currently stands on these questions. So the green here is opposition, and blue is in favor of the statement of favoring a national health plan in which all Americans get insurance from a single government plan. So you see back in the late 90s that this was generally opposed by a majority, 53%. It didn't really change much, but then starting in 2008 and after, we do see with a little bit of noise that the majority of the public supports this view. And so we are up to 53% right now, and it was as high as 57% earlier this year, and 59% last year. So there is support for this notion. But it depends a lot on how you frame it for people. So this is 4 different framings for the notion of universal coverage, right? So we have Medicare for All at the top, quite popular, 76% of Democrats in favor, 61% of independents, 41% of Republicans. If you just make this a generic phrase of universal health care, where you don't actually specify how people are going to get that coverage, the numbers tick up slightly for Democrats, basically the same. Interestingly, independents drop down a bit, and Republicans are about the same where they were. But if you say socialized medicine or single payer, you actually see a significant reduction in support in all of these groups, Democrats, independents, and Republicans. And so I think that's part of the answer of why we're hearing Medicare for All to describe a lot of different policies, even ones that aren't really Medicare for All, because it's a popular branding. So this is where that slogan as opposed to a real policy emerges. And this tells you part of the struggle that while people might support the idea of getting everyone insured, people start to differ when they hear the details. And then this slide puts a little bit more of the policy trade-offs in front and center. Now, I will say I don't love all these options because they're highly loaded. So, for instance, the top line that it leads to delays in people getting some medical care and tests and treatments, it's not clear that that will happen under every version of universal coverage. So the ACA, for instance, led to 20 million more people. There's no detectable increase in waiting times for the general population. There's been no kind of overflow of the system where people haven't been able to manage it. So it's not obvious that every universal system would lead to these sorts of delays. It's certainly possible. And meanwhile, if you go down here to eliminate all health insurance premiums reduced out-of-pocket health care, well, yes, some single-payer models do that, but not all of them. You can keep copays in some versions of this. But not surprisingly, if you tell people they have to wait longer, they don't like it. If you tell them it's free, they like it. The more interesting one, I think, is in the middle, which is you tell people, well, what if we do this but we eliminate private health insurance companies? The majority of people oppose that. So why is that? When most people support the idea of universal coverage, and this comes back to what do you have now? And even though there are 40 million people who are underinsured, there are 150 million people with employer coverage, and there are 50 to 60 million with Medicare and 70 million with Medicaid. So that means that a lot of them are not underinsured, and a lot of them may want to keep what they have and are scared of the unknown. So when we think about the politics here, we have to remember that we're talking a lot about what's going to happen to the 10% who are right now without insurance most in need, and the other 10 to 15% who are not getting great coverage. But that's a lot of people whose coverage is relatively satisfying to them who now wonder, well, what happens tomorrow? Or in 4 years, depending on what plan you look at, or in 10 years. And at a minimum, even if everything goes swimmingly, there is a large one-time disruption for 70 to 80% of the population, right? Now, the question of how you manage that, and can you do that smoothly or versus do you do that poorly, is an implementation challenge that's sizable but potentially manageable. It's not, in other words, it's not just where we end up and how we get there. And if you look at the Democratic plans that have come out, some of them tackle this by just extending the window and say we're going to wait 10 years and do this very gradually. Some do it faster. Others say, well, let's just let people buy in if they want to, and maybe in the long run, ultimately everyone's going to want it, and then we'll end up at single payer. That's the kind of 20 to 30 year horizon maybe. So this is why it's not straightforward and why it's not easy, even if there are a lot of policy arguments for it and that many people agree with the general idea of it. So let me wrap up there and say, there are strong ethical and public health arguments for universal coverage. There is no doubt about it. I think the evidence base is very strong on this. People gaining coverage are going to live healthier lives. They're going to have better financial protection, better, more equitable health care. But single-payer plans do face real trade-offs, and the devil's in the details. Do we want to save a lot on administration by doing away with consumer choice? Do we want to negotiate price reductions to make this more affordable at the expense of alienating physicians and hospitals, both politically and some of them deciding not to see patients? How do we deal with the affordability of out-of-pocket spending versus the total cost? If we want to make this free for everybody, it means the total tax bill is going to go up a lot more than if we say, no, we'll keep some copays and deductibles. And finally, how do we get to there when we have 90% of people who are going to be switching coverage in one form or another? Thanks so much for coming tonight, all 150 of you, and I'm happy to take your questions and comments now. Sure, do we have a mic, or how do you want to, I can repeat your question if you're, are you going to, all right, excellent.
I think we have.
We'll do that too. I will definitely repeat them. But, so while we're, okay, we'll start with the president, the chair's prerogative.
Okay, I'll try to speak loud here. The operation, how do we get there from here? The next day, there's going to be a big transition for people with employer-based health insurance in that suddenly the premium the insurer is paying is going to go away, and the tax the employee is paying is going to go up. And that is going to be a sliding scale instead of a single premium. The lower paid employees are going to pay less. The higher paid employees are going to be paid a lot more. How does that transition work? How do you guarantee that the employers are going to return to their employees the money they were paying for premiums, and that the higher paid employees aren't going to rebel in some way because of the change?
Yeah, well, those are two different questions, right? So the first question of, well, what happens if we shift 150 million people and all of their associated healthcare spending into a federal program? So the basic economic logic here is simple, that you have money that you're either paying in premiums or that you're paying in taxes to support it. Now, premiums and taxes aren't completely replaceable. Taxes do have other negative consequences in terms of incentives, but overall the big picture here is we're going to shift this over, and if we have administrative savings and maybe some lower prices to clinicians, we can actually charge you less in taxes than we were charging you in premiums and copays and deductibles. And that logic it holds. It doesn't hold for everybody because taxes are typically progressive. They're higher for higher income people. That's mostly a political question of, can you get that through, and will employers and higher income employees be willing to go along with that? The question of, well, how do we know that the workers will get that money back? this is just standard economics, right? That the competitive economy here. That if let's say that tomorrow we get rid of all of the premiums that everyone here who works in the Harvard system is paying, and instead we're going to pay it through taxes. Will Harvard then increase our wages? Well, if Harvard doesn't, some other school is going to come along and say, hey, you know what? We'll pay you that money because we're also no longer having to pay the health insurance. So in any competitive labor market, eventually the employers can't just hold on to the money, right? If they try to do that, someone's going to have the incentive to peel off workers. So right now, employers basically look at two things. They look at the cash wages and the non-cash benefits, and they decide total how much they can pay you. They don't way underbid that if they want to keep a workforce. Otherwise, they lose everybody. And so that logic would still apply. So in the long run, the wages would, I think, capture most of that. And there's evidence that to support that based on prior studies of the labor markets and insurance benefits. But that doesn't get around the political challenge of, do you get employers that are willing to buy into this, and that the higher income workers are willing to pay a bigger burden than they do currently. Though, if you make enough negotiations and cut prices, that burden might be less than you'd expect.
So we have about 10 minutes for questions total. So please make sure you ask questions.
Yes, Dr. Sommers. One of the major problems that clinicians have in caring for patients is their choices for their patients are limited under the current program. Certainly, secondarily, the patient choices, but the practicing doctors themselves are limited, due primarily to insurance company restrictions. Pre-authorizations and let's go on, and then the deductibles and the co-pays. Patients are really limited, and the doctors are. And yet those under Medicare, certainly my experience has been before Medicare and after Medicare came in 65, there's a world of difference. The playing field is leveled, and yet you say that under Medicare for All, choices will be limited. I don't really understand that.
So again, I want to be specific about what choices are limited. A single payer model limits people's ability to pick different types of insurance by definition, right? If you start now where we have dozens of types of insurance that people can pick from depending on their circumstance, and we say everyone's going to have the same kind, you don't have any choice of insurers. That may not be a priority, and if you think that if you set up the system in a way you think that gives people more choice of clinicians or a broader hospital network, that could be a net win for people in terms of choice. So I think it's absolutely true that there are aspects of choice we should care about beyond what number of insurance plans you have. But on the other hand, I imagine, has anybody in here ever done comparative shopping to decide what insurance plan they were going to sign up for through their job or through the marketplace? So everybody who's raised their hand saw some value in spending their time picking an insurance plan. That goes away if you give everybody the same plan. That may not be a big deal to you. That may not be a problem in the specter of getting everybody covered and in simplifying the system and in giving better financial protection. I'm not going to tell you my own take on that for my own family, but I'll tell you that there are some people who will take that gladly, and some people will say, I'd rather have the choice. So it's simply one of the trade-offs that we have to factor in, and that's one of the reasons we see the emergence of options like, well, let's keep Medicare Advantage around, or let's have a Medicare if you want it approach as opposed to a universal Medicare for all.
You noted that there was a substantial political implication between calling something socialized medicine or single payer.
Yeah.
I'd like you to dig into that a little bit deeper, in the sense that if there is a single payer, no matter how those dollars are distributed to either individual members of the physician community, the hospital community, whatever, they're essentially the ones who are responsible for paying it. And therefore, whatever the individual provider group has available to it will ultimately depend upon what the federal government decides to pay for it. So the organization of the structure may vary in that they may have different organizations, i.e. the way you've described it. But ultimately, if there's a single payer, won't they ultimately decide how those dollars are spent, no matter what the organization?
Well, I mean, I think there are two different issues. One is what does the benefit design look like? The same way it does right now, Medicare makes centralized determinations of what's going to be covered and what isn't, right? And there's some, there's some treatments that aren't covered, and they're, that's an inherent feature of having a health insurance plan is deciding what you do pay for and what you don't. Medicare doesn't pay, for instance, for vision and dental, right? And that's a feature that if we have a single Medicare for all, that will have to be decided by policymakers of what they cover. But then separate from that is, do the providers work for the government or not? And in all of the proposals we're talking about, the clinicians and hospitals still work, independently. The insurers have rules as to what gets reimbursed, but the doctor gets to decide, what office do I go to? Where am I going to locate myself? Which, and what's my schedule going to be? I mean, none of these are like set by the government because they're not working for the government. So maybe I'm missing your question, but clearly the government policy will affect what services are available and the choices clinicians make, but none of these proposals have all clinicians working for the government.
Maybe I can clarify a little bit. If ultimately there is a single payer that determines where those dollars go, doesn't that ultimately determine what the structure of the provider network will look like?
I mean, not necessarily.
Can you repeat the question, please?
Yeah, so the question was, if you have a single source of the funding, doesn't that dictate the structure that the healthcare markets will take? No, I mean, you don't have to do that. I mean, Medicare can be a very passive payer. I mean, currently in fee-for-service Medicare says, here's what we pay for these services, and then doctors and hospitals decide if they want to see those patients. There's no, Medicare requirement that you have 3 doctors in your practice or how many, specialists are in your referral network. That Medicare generally takes that hands-off approach in the fee-for-service model. You could do a highly regulated version of single payer, but you don't have to. So you could basically say, well, here's how we pay the bills, but you decide what to do with it.
Well, thank you. My name is Mel Klaas, and first of all, I congratulate you on presenting a very complicated issue very clearly. I've always been a devotee of a single payer, number one, and I don't know why, and to begin with, if you simply had Medicare as a defined contribution plan where we made our premiums for it, et cetera, funded by the government, why you can't get that passed more easily than a shotgun approach and let it simply work into finally where you would get down to a single payer.
So when you say defined contribution, so is this optional or is everyone required to do it?
It's like another insurance plan. You pay, the individual pays a premium to the government. I'd like it funded by the government because, and let that plan compete with the others. And I think that the public would buy that, into that, and then eventually you would get to a single payer rather than to take the whole bale of hay in one bite.
Yeah. So, the idea of a Medicare buy-in or optional Medicare coverage for everybody has the advantages of not forcing people out of coverage they like. It's politically certainly more incremental. The downsides of it from a policy perspective are you don't get any administrative savings, at least not up front, because you still have all these other plans out there that are still existing, and you don't get everybody covered, right? These optional patchwork systems, like the Affordable Care Act, you have 15 million people who are eligible for this plan, but they haven't signed up for either subsidized marketplace coverage or Medicaid. So if the top goal is getting everybody covered, a Medicare buy-in doesn't get you there, but it does move you in that direction. And I think honestly, this is why both liberals and conservatives see it similarly, which is as a public option or Medicare buy-in a backdoor over the long term to single payer. I think they both see it that way, and that's probably why liberals like it and conservatives don't. Micah.
Yeah, so I wanted to go to your observation about what happened when the ACA was passed, where 20 million more people got insurance, but healthcare costs didn't really take up that much. And as you said, there didn't seem to be any detectable difference in the wait times for other people in society. So the question is, are there lessons from the ACA implementation for how much we would expect spending and use to change under Medicare for All?
Yeah, I think one of the important things is just to keep in mind the arithmetic, right? So the ACA insured 20 million people in a country of 300 million, right? So well under 10%, right? And we also know from the studies that have been done over the years that when people gain health insurance, they use maybe 30 to 40% more in terms of total healthcare spending. So if you do that math quickly, we're talking a 3% increase in total healthcare utilization nationwide. If we go to something like a single payer that goes from 30 million to 0 uninsured, we'd bump that up a little bit because it's more people, but it's in the order of 4 or 5% more. So, you know, if the lines are 4% longer at your doctor's office, would you notice? Maybe, maybe not. You'd hear plenty of anecdotal reports of, well, I can't get in now, but we know that that's true now too. So I think it's not, in some ways here, the blessing and the curse of this is it's affecting a modest share of the population, and that's why it wouldn't, I don't think, completely disrupt how people get care now. But that's also why it's hard for a lot of people to get on board with it, because it's 90% might say, well, we're okay, or 80% might say, we're satisfied where we are. Do we need to overhaul the whole system to get that extra 10% covered? Now, extra 10% doesn't sound like it's that much, but when you realize it's 30 million people, you're like, yes, that's a lot of people who don't have a way to get into healthcare now. So I think there are some lessons here in framing. I think concerns about overflowing the system and overloading it are probably, I would say, overblown, to use the word over 4 times in a row. But I think the concerns about will there be available providers? Will there be access? I think the answer is from the ACA is, well, yeah, there will. People who went from uninsured to insured will clearly be better off. As to the total cost impact, most of this is chump change compared to how much do you pay doctors and how much at hospitals and drugs, and what the administrative savings are. Because if you get those savings and you're aggressive with them, you can easily pay for an extra 4 or 5% number of of visits and hospitalizations per year. But if you don't do those things and you're going to make the coverage much more generous, then you might actually spend more. So all of these are choices. These are levers and dials that you have to think about where you want to optimize. What's your sweet spot in these trade-offs?
So I think we have time for one more question.
Thanks so much. My name's Nate. I'm over at Tufts Med School. And we've talked a lot about choice, so I don't want to bring us back to that, but I guess I'm going to. I'm just thinking about your example where if an employer moved people over to a different insurance that covered less, how they didn't do any price shopping to figure out what would work best for them. And so I guess my question is just, do you think there are people out there who, normal people outside of the medical sphere, who place a lot of value in actually the choice about the insurance plan, or is their motivation for their insurance plan seeing a broader network of doctors or going to the hospital they want to go to? And if a single payer plan had a single network where most, if not all, doctors and hospitals are in the network, among other sort of broadened opportunities for consumers, are there people who actually care about the insurance choice? Because I've spent hours looking at insurance choices and it didn't give me any benefit in the long run.
Yeah. I think the cop-out answer is, yes, I'm sure there are some who do. How big a deal is it, and how much of a loss is it to eliminate that choice? I think that's a value judgment. There's no evidence that having a choice between insurers leads to better health outcomes, right? I mean, we just don't have evidence, period, that between the different types of insurance, how much of an effect that makes. We have a lot of evidence that having coverage instead of being uninsured matters a lot. We have very little evidence on which types of insurance are better or worse. So, from that perspective, it's not a public health concern. It's really more of, a question of do we think that people should have some flexibility if they have different preferences? And you can very easily say, no, we don't think you should have that. It's much more important to cover everybody, and we don't even think you'll care at the end of the day. But that is still that's a policy choice to take that flexibility away. We don't do that in schools, right? So we declare a universal right to education, but we still allow parents to send their kids outside the public school system if they want. Do we want to have that sort of option in healthcare or not? Good arguments for and against in terms of equity versus sustainability and parental choice. So I think that framework might be a helpful way to consider it. It's not by any means my top priority. I wouldn't even put it in the top 3 or 4 factors to consider, but it's not a zero issue.
So 2 things. First, I want to invite everybody to a reception just outside the doors at the top. Tara has arranged light refreshments for 130 people, so I think probably there'll be plenty for everybody. And secondly, I want to thank you very much for this speech and enlightenment tonight. Thank you.